Run, 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 run. Run, 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 run. Run for grace to every mile. Scream for life with every smile. Together we stand, strong and true. Run for grace, we'll see it through. Run, 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 run. Run for grace to every mile. In the morning light, we lace up our shoes, running with hope in a world we choose. For every heartbeat, for every life, we run for grace and scream for life. Run, 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 run. Run for grace to every mile. Scream for life with every smile. Together we stand, strong and true. Run for grace, we'll see it through. With every step, we break the chains, lighting the path through joy and pain. For those we love, for those we have lost, we run for grace and scream for life. Run, 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 run. Run for grace to every mile. Scream for life with every smile. Together we stand. Run, 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 run. Run for grace to every mile. Run, 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 run. Run for grace to every mile. Run, 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 run. Run for grace to every mile.
Good evening, everyone. Welcome to the another session of cancer awareness program that's organized by uh, Grace Cancer Foundation. I'm Dr. Swami. I'll be the host for the evening. I am about to introduce a stalwart of uh, you know Kolkata, Professor Pranta Chakravarti. Sir was working as a professor and head of the Department of Hematology at NRS Medical College, Kolkata, till the July 2019 when he decided to develop cybernetic care. He's a graduate from one of the oldest medical colleges in Asia, that is the Kolkata Medical College, and pursued his MD in medicine from the Institute of JIPMA, Institute of Postgraduate Medical Education and Research, Kolkata, and did his DNB in internal medicine and DM in clinical hematology from All India Institute of Medical Science in New Delhi. Prior to joining the NRS Medical College, Sir was instrumental in setting up and developing the Institute of Hematology and Transfusion Medicine at Medical College, Kolkata, a designated center of excellence now. After joining the NRS Medical College as a professor in 2014, Sir had shouldered additional responsibilities as a nodal officer of multidisciplinary research unit and was the principal investigator of uh, DBT Nidan Center of Excellence in Genetics. He was also the nodal officer of National Knowledge Network under the auspice of NIC. He was the subject expert in Hemato-Oncology Subject Expert Committee, Government of India, and was nodal officer for the State Thalassemia Central Program, the Government of West Bengal. Sir was actively involved in designing and validating a point of care non-invasive diagnostic device called the AJO, which can detect the hemoglobin, bilirubin, and oxygen saturation levels in blood by just by shining light into the eye. Right now, Sir is working with the Zoho Corporation Tenkashi to develop an accessible and affordable rural healthcare delivery model. He's also a visiting professor at the School of Public Health at Sri Sri University, Cuttack. Sir has also worked as a senior consultant, research and training center for digital healthcare technology, Maulana Abdul Kalam Azad University of Technology, West Bengal. Sir has been a mentor for Rotary Life Beyond Cancer and Comprehensive Sickle Cell Disease Care at ICMR Center for Research and Management at Chandrapur, Maharashtra. Sir also works with a global charity effort called the Hemoglobe Global at Canada and Sri Lanka. His passion to build a team of dedicated healthcare providers who will provide quality and affordable care with significant outreach and community participation uh, through effective leadership and community skills is commendable. Welcome, sir. We are proud to have you with us. I request you to kindly initiate the talk on the ABCs of blood cancer.
Yeah. Thank you, Dr. Swami. It's always a pleasure when we can disseminate knowledge, as knowledge is also progressing fast. And what I'll try to do today is, so as was mentioned, that we will be talking about the awareness, the breakthrough, and what is important for the person is the care to be given in case blood cancers. Now, you can spend days together on a single blood cancer, but in the next 40 minutes or so, I'll try to give you a helicopter view of the entire scenario. This is my email address. So today's journey would be about awareness, recognizing the warning signs and know when to seek help so that diagnosis is not delayed. What are the recent breakthroughs in terms of diagnosis and treatment, and survivorship, care, and practical actions so that we have very good outcomes. So, blood cancers in India today, if we look at it, cancer is always depicted and people think that cancer is 4% of the childhood cancers that is affecting children 0 to 14 years of age, but they have a 70% cure rate. In so-called developed countries, this is now reaching 90 to 95%, but we are still lagging behind. There's a gap. We can discuss it in another forum. So leukemia leads the childhood cancers, followed by lymphomas and brain tumors. And cancer registries are expanding and they are helping us know what actually happens. What I want to tell you today is that the hope is real. With timely diagnosis and modern therapy, many blood cancers can be cured. And some of the chronic cancers, we have converted it into chronic disease. So it is get well soon for everyone. Now the warning signs. Now remember, blood cancers can be roughly categorized into acute and chronic in terms of leukemias, where the white blood cells are affected and then the red blood cells go down, platelets go down. But there are other cancers which are directly not starting in blood. Those are the lymphomas, which started in the lymph nodes. So what are the general symptoms? Persistent fever and unusual tiredness, pale skin and weakness. So what we call pallor, unexplained weight loss. This can be a sign of any malignancy, but in India, we also have tuberculosis. It can be due to that. In blood cancer, specifically in leukemias, you can have bleeding signs in the form of easy bruising or bleeding, frequent nosebleeds, or purpura or petechiae, even without injury. Then you can have other physical changes, right? And what can be those physical changes? Painless neck or groin swelling. Why? Because lymph nodes. So lymph nodes can be affected in lymphoblastic diseases, including lymphomas, bone or joint pain. Like in children, sometimes these are misdiagnosed as arthritis, recurrent infections because your immune system is compromised. So when should you act? What is the red flag timeline? If symptoms are persisting for more than 2 to 3 weeks, you should consult a hematologist or a oncologist immediately. And the big test you always, especially blood cancers, is a complete blood count, because early detection saves lives. And trust your instincts when something doesn't feel right, especially children who may not be able to express their symptoms clearly. So common blood cancers, as I told you, there are several, but we will pick up one by one. Commonest, which are the most dangerous, are the leukemias. They can be acute by definition. If you do not treat an acute leukemia, people, be it a child or an adult, will not survive beyond 6 months. And it comes as a thunderstorm. Chronic, this can go on for quite some time, and we have CML and CLL. Just like in acute, you have ALL and AML. So what are these L and M? So if you look at the blood cells, there are mainly two lineages. One is the lymphoid, which are, lymphocytes. Then you have the plasma cells, which actually create the cells called immunoglobulins. And myeloid gives rise to neutrophils, also eosinophils, basophils, and even the platelets. Okay. So you can have even cancer of the platelets where the platelet count can go up, but those are very rare. Then you have lymphomas where the lymph nodes are the harbinger of the disease. And basically, we classify these lymphomas according to Hodgkin and non-Hodgkin. So Hodgkin was obviously a person, and this is an eponymous nomenclature, but non-Hodgkin actually is a basket of almost more than 50 different types of lymphomas. On the whole, Hodgkin is better than non-Hodgkin. I think this knowledge is enough. And then you have myeloma, which we sometimes call as multiple myeloma. This is a malignancy of the plasma cells, but they can present to different people. If there's bone pain, they can go to an optician. If they have severe anemia, they might come to a physician or hematologist. If they have kidney problems, they may land up with a neurologist. But these are the main problems of myeloma I'll again discuss. And beyond the traditional cancers, you have bone marrow failures like aplastic anemia and myelodysplastic syndromes. I'll not discuss them today, but they are treated similarly to blood cancers. So we told you something about the A of blood cancer. Now let us come to the B of blood cancer. What are the breakthroughs in diagnosis and management? Now, when a person has leukemia, those cancer cells are called blasts. Okay, they can be seen on peripheral blood using a microscope. And if they are more than 5%, even after treatment, then we say that the disease has not gone into remission. But we have now realized that even if it is less than 5%, still those cancer cells hide within the marrow. And for measuring that, we have measurable residual disease or MRD. The two main techniques used, you need not go into the details, is flow cytometry and molecular techniques like PCR. Now we have next generation sequencing. So instead of 5%, we can detect 0.001%. Why is this important? Because if you can take care of these cancer cells, the better kill you achieve, the chance of the disease coming back is less and less. And in acute cancers, if it does not come back in 10 years, we call it cure. The other breakthrough which has come is in terms of gene panels. So in AML, we look at FLT3, NPM, and in ALL, we have something which was named after where it was first presented, that is a Philadelphia chromosome. Now, the beauty of science is, at one point of time, Philadelphia chromosome positive ALL was considered to be the best. Now we have developed drugs against it, and it is considered one of the better prognosis. So that is how science advances. And in terms of imaging, for lymphomas and myelomas, we have something called PET-CT, where it's a nuclear imaging, where we can detect it and we can also decision of how we treat it. Now, I will be discussing chemotherapy in acute leukemia, specifically ALL in children. Why? Because this has the best prognosis. Remember, when I discuss myeloma, I'll again use these three terms. And what are these three terms? They are all plain, simple English. It is induction, consolidation, and maintenance. What is the goal of induction? To kill the leukemia cells in the blood and bone marrow. Then they go into remission. I told you first is microscopic morphological remission, and then we look at MRT. Now, once the leukemia is in remission, the goal of consolidation, or some of us use the term intensification, is to kill any leukemia cells that are hiding in the body, which can cause a relapse. So this is the first step of the war. This is the second step. And third, this is specific in ALL, that we use maintenance therapy to kill any leukemia cells that may regrow and cause a relapse. So what are our goals in treating any cancer? It should be efficacious, but it should also be safe. So we should not undertreat anyone. We should not overtreat anyone. So all the people who are listening today, you have to understand that in these phases, we use certain drugs. Some of them were discovered almost 50 years back. The first drug which used to be used was steroids, and we still use them. Then we used vincristine, and then we use a group of drugs called anthracyclines, doxorubicin or daunorubicin. The most important thing the family will understand is that induction phase goes on for 4 to 6 weeks. This usually given in the hospital, either through daycare, if the patient is not very sick, or through admission. Then consolidation phase, we use certain drugs, but it can be as long as 6 to 9 months. It can have an interim maintenance phase, and in childhood ALL, we use methotrexate to kill the cells which hide, where they hide within the brain and they hide within the testes in males. So we use this consolidation. And then we use maintenance, which is mainly oral drugs like 6-MP and methotrexate. Sometimes we use pulses. This can go as long as 2 years. So if you add 6 to 9 months, 2 to 3 years plus 4 to 6 weeks, it can be as long as 3 to 4 years of treatment. So it's not just, you have malaria, you're given a treatment and you improve. Now, what are the breakthroughs which have happened in the last 10 years? As I told you, we don't want to undertreat anyone. We don't want to overtreat. We are doing risk adaptation using MRD. That itself is a 3-day symposium. But remember, MRD guides us whether we should use intensive therapy or less intensive therapy. Second thing is, we have now developed monoclonal antibodies like blinatumomab and inotuzumab in high risk and relapsed ALL. So every patient might go into remission, but they can relapse also. So in relapse, the initial drugs don't act. Previously, we used a lot of toxic chemotherapy, which was not tolerated by the patients. Now we use these monoclonal antibodies. Unfortunately, these are expensive. The third breakthrough which has happened is cellular therapy. We call it CAR T, means T cells. So lymphocytes are essentially T cells, B cells, and natural killer cells. So we modify the T cells so that they can kill the tumor cells. And fortunately, we have 2 to 3 varieties of Indian CAR-Ts, which are far less expensive than which are available in the outside world. So now, other than chemotherapy, which is more like carpet bombing, we are using targeted therapies like we used in Operation Sindhu. And you have bispecific antibodies like blinatumomab targeting CD19, glofitamab, and rituximab. We also antibody drug conjugates has a chemotherapy along with that antibody, go and kill it. And we also have in myeloma monoclonal antibodies like dupilumab and isatuximab. The time will come when these will be discussed, but these are not usually used in the frontline therapy. Frontline therapy, we still use chemotherapy. But the most important thing you have to understand is it is about a prescription, right? We write something and this is treatment. It integrates growth monitoring, neurocognitive assessment, leads to cognitive problems. And patient follow-up. Ensure children not only survive, but they thrive. So this has the best prognosis, childhood ALE. What about adults? It is not such a good disease. And again, we look at whether they are pH positive, they're more. And I told you we use tyrosine kinase inhibitors there. So there are a number of these drugs. You might have heard of them. Imatinib, dasatinib, imatinib. You have another inhibitor called axitinib. So depending on the MRD and depending on the specification, we decide what kind of chemotherapy to give, whether we should use monoclonal antibodies, and then if those don't work, if they have a donor, do an transplant. This is the story. Frankly, this is one of the worst cancers in the world. So whether the patient is eligible for IC. What is IC? IC means intensive therapy. 7+3, which is like carpet bombing, we try to buy it, but now we have called venetoclax, azacitidine, and some targeted therapies like viltetinib, sorafenib, midostaurin. Depending on what kind of mutations are there, we use them. So we are trying to become smarter in AML, but the prognosis is not as good as AML. But are all AMLs bad? Within AML, we have a blood cancer called acute promyelocytic leukemia, where most of the time we don't use any chemotherapy. Okay, you see all rods in the cell, and in non-high risk, we do not use chemotherapy. We use something which was used long back, that is arsenic trioxide, and also ATRA, which is all trans-retinoic acid. So here's what we use it for. We know that those cancer cells, they can be reformed to become cells, normal cells. And these drugs can use us. So, you keep the criminals in a reformatory home and they become normal and they are cured for life. If it's high risk where the white blood cell is more, then you have a problem. You might have to use chemotherapy, but the greatest problem these days, there's a high chance of bleeding. So, and bleeding of optimal lymphoma. So, what happened? The advances in adult leukemia, as I told you, we have a drug venetoclax, which was started to in CLL, chronic lymphocytic leukemia. I won't discuss it in detail because it takes a lot of time. That now used in layman. Then you have targeted therapies like FLT inhibitors, IDH2 inhibitors. Can you hear me now? Sorry, my
Yes, sir. Yes, sir.
connectivity disappeared. Okay,
You're audible
yeah,
now.
I'm back. So what I was trying to tell you was that in CML, you take a drug and we monitor your measurable disease every 3 months. And if you go into remission, we now have something called treatment-free remission. We can stop the drug. In CLL also, we have oral drugs like ibrutinib, acalabrutinib, but they have to be taken lifelong. Okay? Now, what about lymphomas? So as I told you, you have Hodgkin and non-Hodgkin. Hodgkin, common in children as well as in adults. Classically, we use certain chemotherapy, which is called ABVD or Biacop, and then we are adding monoclonal antibodies like nivolumab and brentuximab now. DLBCL, I can go on for a week, but what are the options there, right? There are certain low grade where we just wait and watch and we call it active surveillance. Then we use certain targeted therapy. I talked about rituximab. We also give chemotherapy. Commonest in non-Hodgkin is CHOP, C-H-O-P. Sometimes we use radiation therapy, and sometimes we are using immunotherapy if the disease relapses, like bispecific antibodies and CAR-T therapy. So now you have monoclonal antibodies called polatuzumab, which is replacing vincristine. You have bispecific antibodies like glofitamab and epcoritamab. And in Hodgkin, you have something called brentuximab and PD-1 inhibitors. That's all about lymphomas. If you remember what I told you about leukemia, we have now taken concept into myeloma as well. So in induction, we use 3 to 6 cycles of 3 or 4 drugs. What are those drugs? One is again steroid. One is an immunomodulator like thalidomide, lenalidomide, pomalidomide, which is lenalidomide is called Revlimid. And then we also use something called proteasome inhibitors, which are called bortezomib, carfilzomib, ixazomib. Don't worry about the names. What I'm trying to make you understand is induction is 3 to 6 cycles. We consolidate by something called autologous stem cell transplant. And then we do maintenance. If they're not fit, then we continue this. If they're not fit for a transplant, we continue for almost a year and we give maintenance. This is about myeloma. What has been the revolution in myeloma? I told you about these drugs, proteasome inhibitors. Fortunately, India has generic versions of most of them. And then you have CAR-T therapies, BCMA targeted. You also have monoclonal antibodies called daratumumab. And then you have a concept of maintenance now, and MRD has now entered the arena. That MRD can be through PET-CT, and also through flow cytometry. So we are slowly transforming myeloma into like ALL. But in myeloma, how the patients present? They can present with CRAB. Okay, what is CRAB? High calcium, renal disease, anemia, and bone disease. So as I told you, they can present to different specialists and they need treatment. We usually do an autologous transplant, which is like high dose chemotherapy with stem cell rescue. Stem cell transplant is a curative treatment for many, but you have to have a donor. The best donor is a HLA matched sibling, otherwise matched unrelated donor from registries or half matched donors. So you have DATRI and DKMS DMC registries where you matched unrelated donors. Remember, cancer is an immunological disease. Each one of us have cancer cells developing in our body. If our immunity is not strong, they cannot kill it. So we are now taking your immune cells, modulating them in the lab and giving it back. That is called CAR T therapy. Okay? So those were the breakthroughs, B. Now I come to C. C is all about care, supportive care which saves lives by preventing infections. The most important infection prevention is hand washing, nursing, which do not cost much, so they do not look very attractive. Whatever we do during COVID, we have to follow it to save the lives of these patients. Another important is fertility preservation in adolescents. So sperm egg preservation is done before high-risk therapies. Nutrition, we do not know much about that, because we feel, okay, they will be miserable. But if they are not taking their food, then the drugs will not act, and it will show that nutrition rehabilitation helps improve the outcomes. So protein adequate diet, exercise, physiotherapy, and bone health monitoring. Mental health matters. At the end of this month, long podcast with a psychiatrist where I'll be talking about mental health. Stigmatization affects the patients and their families. How depression and anxiety can take away the good prognosis. So mental health is as important as physical health. We should celebrate life, but survivors be monitored, which includes cardiac monitoring, endocrine assessments, cognitive evaluation, their school scholastic performance, and sometimes chemotherapy can lead to cancer. So we need to do a second cancer surveillance to help them thrive in life. Affordability is an issue. Some of the newer drugs I've discussed are very expensive. But fortunately, we now have mass insurance in the form of Prime Minister Insurance Scheme, ABPMJ, which is Ayushman Bharat, up to 5 lakh per family. There are state schemes like in Telangana and other states. In Bengal, there's Shastro Shati. And then you have a CSR and an NGO support like Grace Foundation. CSR support is there even for transplant, for drugs, diagnostics, and travel. And if you deliver it through daycare and you use generics and you optimize the care, then the cost can be reduced through a. So what common people can do, right? You have to know the warning signs. I've told you, consult medical professionals early. Do not believe in WhatsApp University or Google Doctor or ChatGPT or Gemini. Keep the childhood and adult vaccinations current because vaccines can prevent certain cancers, though not cancer. Register the stem cell donor so that you can donate those stem cells, give new life to the cancer patients, and most important is to support the families, which I call as handholding, which I do through mentoring of live cancer project of Rotary. They might need to write to a funding agency. They might need to write to their employer why they are so much absent. Help them, fundraise them, advocate them for coverage wherever they are, because access is the most important thing. How do you navigate your care? You start with a specialist, you understand your journey. Show you it can be for 3 to 4 years. You should visualize it and get ready for it. Seek expert opinions like Tumor Board. We have a national cancer grid, especially for rare and relapse diseases. Ask about clinical trials which are available with the newer drugs now. And maintain your records very well. If they're digital, it's fine. Even if it's paper and pen, always scan them and keep a digital record. So, Indian resources are there other than Ayushman Bharat and other schemes. Donor clinical trials, but I think NGOs are playing a very important role. So you have candidates, you have Life Beyond Cancer, and you have Grace Foundation, which is hosting the show today. There are so many people there who are willing to hold your hands. So the key messages to remember are every cancer should be detected early. Blood cancer is no exception, but blood cancer does not have stages. Leukemia does not have stages. They have risk, but lymphoma has stages. Multiple myeloma has stages. They are treatable, curable. Modern diagnostics and targeted therapies are transforming the outcomes. Treatment access is expanding through public schemes, innovations, and NGOs. You should be aware, you should seek care timely and community support. If we have 1.4 billion people, I don't believe one should be lonely and alone in this war against cancer. So to from recognizing systems to supporting research to donating for better access, we all have a role. Don't think I can do it. You can do a lot. Please go ahead. These are my social handles. We can make breast cancer of the past through awareness, early detection, and comprehensive care. Now I hand it over to Dr.
Thank you, sir, for the excellent speech. It was quite enlightening. So, sir, if you are okay with it, a few questions that I would like to pose.
Yeah,
Uh,
definitely. Otherwise, I think
s-
everybody was sleeping.
no, no,
So
no, sir.
please
I'm
ask
sure
me
nobody was
questions.
sleeping during this thing. Sir,
Yeah.
one common question for this thing would: how different would you consider blood cancers from other solid organ cancers that we usually deal with, sir? When in terms of treatment and
That's a very
diagnosis,
good question. Yeah. Even in terms of presentation, right? As I told you, blood
yes,
cancers like leukemias do not have a stage, right? And
yes, sir.
acute leukemias.
Audience, could you just please wait? Sir is going to join in a couple of seconds. So can you unmute yourself? You're not audible.
Okay, sorry. Yeah. So I'm back.
Yes,
So
sir.
what I was trying to tell you is that acute leukemias come as a storm, right? And
Yes,
people
sir.
say, oh, how did it come? You never know. And most of the times we do not know how they come. So that is entirely different from solid tumors. Solid tumors, we say, was there a lump? Did you notice anything abnormal? Was there a skin lesion? All those things, lungs, something. Blood cancers come, they just come, and you have to understand you become weak because your red blood cells go down. You get recurrent infections because your white cells, though they increase in number, but those are all cancer cells. They're good for nothing and they kill themselves. And platelets, if they go down, then you have bleeding manifestations. So that is the difference. But how do chronic blood cancers come? Like CML and CLL. You might not even notice. Many CMLs are detected during routine blood checkups, right? Some might have some enlargement of the spleen. So you get time. But remember, CML also has stages, though we don't call it stage. Chronic phase is the best CML, where you take a drug and it goes into remission. But if it goes into accelerated phase or blast crisis, then the prognosis is not that good. So that's why, even if you're fatigued and routine blood checkups, that's why we say just a complete blood count helps you.
Yes.
And whatever diseases we call which are of elderly, they happen a decade earlier in India. And for myeloma, well, that is someone which can present, just a back pain. You do a blood test, your ESR is high. Or just anemia. It's not iron deficiency, it's not B12 deficiency. Or, you are a diabetic, your creatinine was borderline, suddenly it starts rising. Later on, that will also give rise to the suspicion. So nephrologists tell me when I work with them, they detect more myelomas. So each blood cancer has its own signatures, but they are different because of the phase of acceleration, and treatment wise, it is so long that sometimes in ALL it goes on for years. AML usually 6 months, but ALL has a 50% chance of relapse. So it might be that it goes on and on. Myeloma, per se, we call it still an incurable disease. So what happens is you take a treatment, you go into remission. Even after autologous transplant, there is a chance of relapse. You again go into remission. After years, you will relapse again to remission. But each time, the results are not that good. But fortunately, with the current drugs we use, we can give a good quality of life to anyone for at least 7 to 10 years. So if you're presenting at 70 years of age, you can go till 80 years of age.
Okay. Sir, would you recommend any specific age groups from when you have to, childhood is obvious, from when you have to start looking for blood cancer screening, sir? Any specific targeted age group that is
Yeah,
recommended
so
as?
yeah, targeted age group, actually, there's none, right? But what I tell people is you will you're going to have fever once in a year. Do a complete blood count. That is so important. Do not do a hemoglobin TCDC. You do a complete blood count, then only, and we will be able to catch those chronic blood
Okay.
cancers. Acute, obviously, the symptoms would be like that. But for screening, I think, and CLL, most of them are during screening, or they were screened for something else to detect.
Okay.
And people will be amazed to know that in CLL, we do not treat at by stage 0, 1. And I have patients who are being followed up for 15 to 17 years without treatment. So they think, oh my God, I have a cancer, but my physician is not treating me. That's a fact in CLL. So there are all types of things. Again, in lymphomas, I told there are indolent lymphomas where we wait and watch. But the
Yes.
diagnosis should be clear. And that's why when you do a lymph node biopsy, people think, why are they asking for immunohistochemistry from lymph nodes and from blood and marrow? Why are they asking for flow cytometry? Because slowly we are classifying them better, and then we can treat them better. So those diagnostic things are important. You might have to spend 10,000 to 40,000 rupees upfront, but that can save you lakhs of rupees if we risk stratify you well.
Yes. Sir, the next question would be regarding the etiology. Are there any known causes or risk factors for blood cancers?
Yeah, so
I mean,
for blood cancers, a known etiology is radiation exposure. So during Hiroshima and Nagasaki, we had a lot of blood cancers, right? So radiation exposure is known. For lymphoma, as you know, there are certain viruses, so you can have Burkitt's lymphoma, though it is not so common here. And there are other lymphomas of the stomach which are caused by bacteria like Helicobacter pylori, right?
yes,
You treat the bacteria, you can treat the lymphoma. But in most cases, especially for myeloma and all, we do not know. But what people should remember is myeloma comes through stages. So you can have a small aim band, nothing. You do not have crab. We call it monoclonal gammopathy of undetermined significance, MGUS. And then you may have something called smoldering myeloma. And then you have frank myeloma. So where you are, at what stage you are detected. So elderly people, almost 3% might have a monoclonal band. So a monoclonal band does not mean it's myeloma. That is
yes.
why it is important that the diagnosis is made correctly.
Okay. Next thing, the common question that we ask, could this be inherited or linked to the genetics, blood cancers?
Yeah, that's a good
The,
question.
yes,
Down syndrome. Yeah, Down syndrome, specifically children, have a higher chance of blood cancer. That is known. And there are certain blood cancers which occur before 1 year of age. There are certain genetic predispositions there. But most of the blood cancers are not genetic, they are not familial, so they are never transmitted. Especially adults with leukemia, lymphoma, and myeloma ask me this question. They are never transmitted to the next generation. There is no genetic basis of that.
okay, sir. And the question that is pertaining to our uh, essence, China sir's essence, do lifestyle factors and environmental factors contribute to causing blood cancer? Because that's the target we try
Yeah.
to
So
encourage people
Yeah,
into
yeah,
physical
yeah. So
activity. Yeah.
lifestyle factors actually lead to some solid cancers. It has been proven, like
Yes,
obesity, smoking. But for blood cancers, except, radiation exposure, other
yes,
lifestyles are not known. But let me tell you, I spoke about acute promyelocytic leukemia. It has been
yes.
proved that those who are overweight and obese, they have a worse outcome. So
Oh,
lifestyle modification is always necessary. Do not be overweight. You can prevent cancer. You can have a better outcome when you're treated with anti-cancer drugs.
oh, it's nice to hear that. And how
Mm.
important is early detection for better outcomes? I mean, just to re-emphasize, we are aware
Yeah.
of it.
Yeah,
Just to
obviously. No, no,
re-emphasize,
no. So what I'm trying to tell you is leukemia, it will, yes, you are neglecting. But, I live in Tenkasi, which is in the remote part of South India. I got a girl who came to me with stage 4 Hodgkin's. When it was diagnosed 3 years back, it was stage 1 then. But because she was afraid of taking the appropriate treatment and she was afraid of the term chemotherapy, she did not get treated. She took some oils and some aroma and all that. And then this disease has become stage 4. And see, stage 1 has a cure rate of almost 100%. Stage 4 does not have a 100% cure rate. So in India, one of the problems is if you are depending on your relatives and WhatsApp University and Google and others, your stage 1 can lead to stage 2, 3, and 4. That is why early diagnosis is.
Thank you, sir. Is there a way to know at the beginning of the treatment if somebody would require an immunotherapy, targeted therapy, or a bone marrow transplant uh, at the initial diagnosis itself?
Yeah.
Because you are
Yes.
emphasizing on having
So
an
that's
established
why.
plan. Yes, sir. I'm done with the question.
Yeah. See, established plan is also important for your financial planning, right?
Yes.
It's
Yes.
not about coping with it, the duration, but it's also about financial planning. So for every disease, we have risk stratification. Suppose even childhood ALL, we have standard risk, moderate risk, and high risk. So we know standard risk has the best chance, who might never need a transplant, and they can do well with the frontline therapy. Similarly, for myeloma, low risk has a higher chance of not requiring cellular therapy and transplant. Transplant there means allogenic. Autologous is also required in standard risk. AML also, like if you have APL within AML, you have a cure rate of more than 90%. So risk stratification and diagnosis can tell you the story, but sometimes it cannot do, right? So we have certain genetic markers, but one thing in ALL which tells the best story is what is your blast cell, cancer cell count on day 8 with prednisolone? Because that gives you a picture, right? Genetics is part of the story, protein is part of the story, drug handling of the body is part of the story. But how you're responding to the treatment and whether it's an early or late relapse, you the story very well. Any relapse, even in a low risk case, is bad. So that is how you can predict. And we are using AI and machine learning algorithms to get this prognostication.
Thanks. Sir, and the next question would be, what would be the timeline and how do you go about monitoring a successful remission in, I know it is over a spectrum of diseases that we're talking, but is there a common thing wherein
Yeah, I think the network does not want me to talk. Anyway, so yeah, so
just
remission wise, it's different diseases,
yes,
right? Can you hear me now?
yes, yes,
Yeah.
sir, you're audible.
So remission, yeah. So for ALL, post maintenance, monitored, so 3 months, 6 months, then 1 year. For lymphoma, also it is similar. But we do not do PET CTs at every sitting. It's clinical monitoring for lymphoma. For
Yes,
CML, it's every 3 to 6 months, right? Unless you have a zero MRD level for more than 5 years. For CLL,
okay.
it is more of looking at the counts. But what is important is please trust your care provider. When they tell you something, it has an importance. Treatment
Yes,
abandonment can lead to relapse. So please follow whatever is being told, and your relatives may know more, WhatsApp University may know more, but please follow the advice of your care provider.
that brings us to our last question, sir. What are the biggest challenges as you see
Yeah.
that are there today in treating blood cancer?
The biggest challenges are accessibility, early diagnosis, right? It's not the family's fault. I've seen people going to the laboratory, getting their tests done. There were cancer cells, they were not picked up. So we are trying to improve the standards of diagnosis. So right now, I am in Tirunelveli and Tenkasi. After this, I'll be sitting with the lab persons. It's not about
Yes.
the doctor alone. In India, the most important is the person who is in the lab, maybe the medical technician, maybe someone is looking at the cell under the microscope. So early diagnosis is a challenge, access is a challenge, and then access wise also the facilities are available only in the cities. When the villagers come to the cities, they are lost. They stay on the footpaths and then they get infected and die. So it's very important that we have a hub and spoke model where the intensive therapy can given in a advanced center. But I have seen doctors refusing to see patients because they have blood cancer. That cannot be done. When they go back to their village or their town, we can guide them, but they should reside at their home. Their parents should not lose their livelihood. If we can do it, I think the outcomes will improve definitely. Because even with free treatment in a government hospital, I've published the data, treatment abandonment is more than 30%. And it's not only due to their fault. They come back, they don't get admitted because beds are full. So the infrastructure has to support the technology and science which is there today.
Thank you, sir. That's all from my side regarding the questions. It was an excellent session interacting with you. I'm sure the audience are quite enlightened with it. Uh, that brings us to the end of the session. Sir, please do not log out. Sir would.
Yeah. Yeah.